Good morning and welcome to our Leadership Matters conversation this morning. My name is Anne Linsell and I'm here supported by Robert and Louise behind the scenes to facilitate this event, which is a series of events which have been running since March, bringing content from nationally and now locally to colleagues to share, to learn and to connect. So just a little bit of housekeeping. We just ask you to switch your cameras and mics off for now. We are recording the session so we can share it onto the NHCP website so that colleagues can watch on demand. Appreciating that not everybody can be here at this particular time. We are going to be using the chat function today, and you can also use the raise your hand function. And I know Chloe will be really appreciative of lots of questions from colleagues on the call. So without further ado, I'm really delighted to be joined today by Chloe Gray and we're going to be talking about all things health inequalities. So I'm going to hand over to Chloe. Welcome, Chloe.
Thank you. So hi everyone, my name is Chloe Gray. I work in the public health team as a public health principal in the health improvement portfolio, but also doing some work with the integrated care system as part of the population health board that's chaired by Lucy Whiteman, our director of public health, looking at how we can work as a system to address inequalities. It'd be really helpful to get an idea of who's joining us and kind of what organisation you're from. So if you could pop that in the chat just so I can get a sense of who's joining, that'd be really helpful. But just as an intro to the topic, I think there's been quite a few reports come out recently that show over the last 10 years, life expectancy has slowed the most in the most deprived areas of the country and has actually slowed down and fallen for some groups. By 2019, there was a nearly 20-year gap in healthy life expectancy between women living in the richest versus the poorest areas of the country. And health inequalities are felt most directly by individuals and communities, but they also do place a burden on our health service. And one study has put the cost of socioeconomic inequality for NHS inpatient hospital services in England at 4.8 billion a year. COVID-19 has really kind of highlighted the inequalities across the country and how different groups are impacted and affected by inequalities. And it's really given us an opportunity to build our society back better and fairer. And we've learned what more we can do to address inequalities and what we can do to put things right. And now NHS England has a director for health inequalities, Dr. Bola Owolabi. And I have recently heard her on an interview, and when she was asked what's her vision for tackling inequalities, she said it's about delivering exceptional quality care for all, but ensuring equitable access, excellent experience and optimal outcomes. So I think that's a really good vision for us all to kind of work towards and tackle inequalities. Next slide, please. So yeah, just to start with, I'm going to talk through what are health inequalities, but just to get an idea of kind of what your understanding of inequalities are. If you could just pop your thoughts or views in the chat box in the Slido, and then we can kind of go on to look at the definitions.
So for colleagues that haven't used Slido before, you can either hold your phone up to the QR code that's on the screen, and your phone's web browser will take you straight through to Slido so you can put your thoughts in there. Or my colleague is going to also pop the link into the chat as well. Or you can go to slido.com and put the code in 78347 and you will it will take you through. So if you just take a minute just to put your feedback into the Slido, that'd be Okay, Chloe, so you can see that some of the responses are coming through now.
Yeah, thank you. So I guess as I kind of mentioned in the intro, yeah, the life expectancy, both kind of life expectancy and healthy life expectancy, differs in different groups, and that kind of shows the inequalities, and different groups have different outcomes and worse outcomes, and it's that gap and variation that we need to address. Yeah, and absolutely, it's about access. So it's about whether people can understand about what services are available, how they access them, and whether they're accessible to different groups, and also the outcomes that people can experience. So there's different outcomes. Okay, so that's great. Thank you. So should we just go on to the kind of the definition and just look in a bit more detail? So health inequality, sorry, back one, that's it. Health inequalities are preventable, unfair and unjust differences in the health status between groups, populations or individuals that arise from unequal distribution of social, environmental and economic conditions within societies, and that determines the risk of people getting ill, their ability to prevent sickness or opportunities to take action and access when ill health occurs. And so there are a whole range of factors that influence our health and our well-being, and kind of this diagram captures it. So it kind of goes from our physiological factors to our lifestyle behaviours, so kind of the food that we eat, whether we smoke, drink alcohol, use drugs, or those kind of risk factors. And then kind of going a bit further out, there's our social and community networks and kind of the people that we're involved with, the access to community resources. And then further out again is the living and working conditions, and kind of education, the environments that we grow up in. And then outside of that is the kind of socioeconomic, cultural and environmental conditions and those kind of political contexts that we live in. And all of these affect our health and well-being. And so different groups have different experiences of the wider determinants of health. So where we live, the conditions that we're working in, the types of work that we've got, the access to services in the environment. The different groups have different risk factors. So people who are from more deprived areas have less access to kind of good quality food, or may smoke more, but that might be driven by the conditions that they're living in. So all these conditions interact, and that affects our ability to kind of cope with the risk factors and day-to-day lives that we're living. And then also there's unequal access to services, and it might be, again, I guess, through whether we know about those services, whether those referral pathways are available to us, whether we, I think research has shown, for example, for planned care, that people from more deprived areas are less likely to get a referral in and access kind of planned care. So there's lots of factors that interact. And if you go on to the next slide, there's another kind of model that presents, it's the same thing but presented slightly differently. But it really highlights that the causes of inequalities and the types of interventions that we need to take that need to focus on the place, because those kind of places where we live, where we grow, where we work, all interacting to influence our behaviour and our physiological risk factors. So we really need to take a place-based approach, because it's those wider determinants that are really influencing and have a much more stronger influence on our health outcomes than clinical services. So again, research has shown that NHS services and the kind of clinical interventions have a much smaller influence on our health and well-being than those kind of the places that we're living, those wider determinants of health. And so we really need to join up across the whole system to tackle that complex pathway that causes inequalities. And interventions that rely solely on behaviour change, such as stopping smoking, eating more healthily, are likely to widen inequalities because of that complex causal kind of pathway that that people might find it hard to eat more healthy food or stop smoking because of the conditions that they're working and living in and kind of growing up in. So it's really important that we work together, and we need to make sure that we address kind of put the resources in the right places and that they're allocated proportionately to address the levels of need in different groups. So we need to really think about health inequalities across the life course from childhood all the way up through to adulthood and older age, thinking about the places that we're working and living in, and having good leadership around that across the system. Okay, next slide, please. So just to kind of give a little definition, because I think inequalities is often used to talk about the whole thing, but actually what we're often talking about is inequity. So this diagram shows the difference between inequalities and inequity. So the first picture of whether the children or people have got they've got the same opportunity there, they've all got the same size box, and that shows apparent equality. So they're all getting the same support provided, but they're still getting unequal outcomes because the smaller person needs a bigger boost to be able to see over the fence. Whereas in the middle picture, it's showing that they're getting equitable interventions. So there's fairness of access because it means they're all getting more equal health outcomes as a result of that tailored intervention. The third image shows that there's equity and equality of outcomes because the barriers are being completely removed. They can all see because there's no barriers. So just good to keep that in mind, that definition, and that the differences between inequality and inequity. Okay, next slide, please. I think mine's still stuck. Is it moving?
It's showing, Chloe, overlapping dimensions of health inequalities.
Yeah, it's only just come through on mine. Okay, so I think inequalities are really complex, and there's lots of factors that cause inequalities, as I've just kind of described through those models. And so when they overlap, so there's lots of kind of dimensions that we need. So when we're talking about different groups that are vulnerable to health inequalities, we really need to think about all of these different groups and how those kind of complex factors can overlap. And then there are some groups that are really vulnerable to kind of really complex inequalities and outcomes and need a lot of support to address those. So we can kind of break it down into 4 areas: the socioeconomic groups and deprivation. So looking at income, employment, and kind of whether people are living in deprived areas. And there's the protected characteristics as defined by the equality duty. And I think quite often that's what people think about when we talk about inequalities. They kind of just focus in on these ones, but I think it's really important to look at the wider picture as well. There's geography, so whether people are living in urban and rural areas and how that impacts on people's well-being and ability to access services and their outcomes. And then there's inclusion health. So I think it's quite an NHS term, inclusion health, but it talks about people who are experiencing extreme kind of disadvantage and exclusion. So people who are homeless, gypsy, Roma, travellers, sex workers, vulnerable migrants, and people who leave prison. So when we're thinking about our county and across Northamptonshire, who's most vulnerable to inequalities and what are the groups that we need to focus on, we need to really think about all of these groups. And so in public health at the moment, we are trying to gather information on these different groups to try and kind of put out a summary document. So when people are planning services, they can, or reviewing whether their service is meeting local needs, they can kind of recognise that there might be a gap, so that if we can kind of show that we've got a certain proportion of people who are from traveller community, but the service data is showing that none of them are accessing their service, that kind of demonstrates a clear gap. So we're just doing some work at the moment. But if you have, what I think we are going to do is start to engage with the community and also put out a bit of a plea for information that you might have, so we can gather that all together and share it more widely. So if you know of anybody that kind of works with these groups specifically or has any information, then pop it in the chat and it'd be good to follow up with them. Okay, so next slide, please. So next we're going to just look at what do we know about the county, so what's our understanding and how are inequalities affecting our residents. So I think I've got a bit of a delay, but I'm on the life expectancy slide. That one, yeah. So so if we look at life expectancy for the different for people born in different parts of the county, we can see that there are different there are gaps and there are inequalities in the county. So a child born in Corby, for example, has a lower life expectancy than a child born in Earls Barton. But also if we track along their life course, we can see that they have worse outcomes across a whole range of indicators around kind of about educational outcomes, about employment opportunities, risk factors such as smoking rates, access to healthy food, and then kind of looking at the health outcomes later on in life, cardiovascular disease risk, cancer risk. So it really does have an impact. Inequalities are impacting people throughout the life course. And when we've done some analysis to look at what is causing that the life expectancy gap, it's circulatory disease, cancer, and respiratory disease. But obviously, as I've described, there's a whole range of factors that are contributing to those, and it's not just a kind of clinical intervention that we need to take to address those kind of clinical conditions. It's thinking about where people are living, working, what they've got access to, what the environment that they're living in, and how that influences their lifestyle and their health outcomes. Next slide, please. And this is just showing where are the most deprived parts of the county based on the indices of multiple deprivation. And the IMD takes into account a whole range of factors. There's 7 different factors that they take into account to around including employment, housing, health. So there's a whole host of factors, and then they look at where are the most deprived parts of the county. So in the west, we've got 17% of the population living in the 20% of the most deprived areas in the country, and that the highest proportion are from Northampton town area. And in the north of the county, we've got 15.5% of the population living in the top 20% most deprived areas, and they are in Corby and Wellingborough. So we know where our most deprived areas are, and we need to kind of think about, okay, what do we need to do to improve the outcomes of those the people living in those areas? How can we improve access to services? How can we influence the kind of range of factors that impact on their health and well-being? And one of the programs of work that we're launching in public health is to recruit and put some community development workers focusing in on those kind of neighbourhood areas, to work with in partnership with communities to understand what it is that's impacting their health and well-being, and to work together to put in place local action plans and to develop solutions and to fund things that will help improve their outcomes. Next slide, please. In terms of the ethnicity of the population, this is based on the 2011 census, so I think it probably has shifted in the last 10 years, and we'll get the more updated information next year. But there is a majority white population. However, I think this kind of profile is different if we start to look at more smaller geographies. For example, in Northampton and Wellingborough, it's a different mix of people. So I think we need to recognise that, well, we've got a kind of county or North and West Northamptonshire profile. The profiles might look differently in different parts of the county where we're working, and so we need to make sure we're engaging with different groups. And I think the work through COVID and the vaccination has really shown how we can work in partnership with local communities to improve uptake to vaccines and get messages out there. If you go on to the next slide, please. It shows that different ethnic groups have different health outcomes, and we've really learned that from, it's really highlighted in COVID that there are inequalities across different groups, but there are differences across a whole other range of conditions. And I think it's a really complex picture across health, across different indicators. And we know, I think, for example, there are in maternal health, we see some really big kind of inequalities and impacts around kind of preterm birth and maternal poor outcomes for maternal, poor maternal outcomes, but also for infant mortality, mental health, cancer. We're seeing that some ethnic minority groups have much poorer outcomes in these areas. However, we, in terms of kind of understanding these differences locally, and I think it's a national issue as well, ethnicity is not routinely recorded. And I think as a result of COVID, there's started to be a lot more focus across the system on how NHS can get better at recording ethnicity. So we can understand those differences, because I think at the moment, if we try and do an analysis for different health services, we get a massive group that kind of says not known or not recorded. And actually, to really understand the ethnic breakdown of people accessing our services and where the inequities are, we really need to get better at recording that data. So that's a piece of work that's going on at the moment to look at how we can get better at doing that. Okay, next slide, please. So this one shows the urban versus rural difference. So Northamptonshire has a lot of rural areas, and I think we need to remember that there is a difference between people living in urban areas and people living in rural areas. So kind of in the urban areas in Northampton and some of the other towns, that they're kind of more densely populated. There's issues around air quality, housing, and more deprived communities. Whereas in the rural, so there's the kind of specific needs that we need to think about with those communities and how we'll address those, and around kind of community safety, those kinds of things. Whereas if we look at those people living in the rural areas, they tend to be older people, people who are isolated, who might struggle to access and get out to services, at a higher risk of falls, and things like fuel poverty as well. So can they afford to heat their homes? And those people living in fuel poverty, again, have a kind of lot of the risk factors. So I think it's really important that we consider that split between urban and rural and what the needs are of those different groups. Okay, next slide, please. And then hidden populations. So I think earlier I mentioned what the term we use as inclusion health. So these are kind of groups that are particularly disadvantaged, and it also includes groups who don't have any financial support and who absolute poverty kind of is a reality. And these groups tend to be socially excluded. And social exclusion is kind of looking at unequal power relationships and how that affects people's ability to access services, to access support, and to kind of get their needs met. And there's a whole range of poor health outcomes associated with social exclusion. So people in these inclusion health groups often have very high levels of morbidity and mortality, with multiple and complex needs across kind of both mental and physical health. And that's kind of presents really complex situations that health services aren't always equipped to deal with, and kind of general population universal based services struggle to address. So for example, here the age of death for people who sleep rough is around 44 for men and 42 for women. People with severe mental illness often have a 15 to 20 years shorter life expectancy than the general population. Gypsy and traveller women live 12 years less than women in the general population, and men 10 years less. Hepatitis B and C infection among female prisoners are 40 and 28 times higher than the general population. So they're really stark differences and really poor outcomes for these groups, and we really need to think about, as a system, what are we doing to address these inequalities and working with these populations to understand and support them to improve their health outcomes. And one of the challenges is, again, as I think I said earlier, we don't have that local data, so we don't necessarily know too much about who these groups are and where they are, and have those relationships. And again, I think the voluntary community sector are really important partners to work with, as they will have better links with these groups. And again, another with the community development workers that we're recruiting, we're also recruiting 2 community development workers to focus on inclusion health groups and kind of gather a better understanding and work in partnership with these groups to address some of these inequalities, but also to raise the profile so they can advocate with health services and commissioners, so that services can adapt and make sure that they're thinking about these groups and understand the needs and what they can do to improve their outcomes. Okay. And again, just as I suppose as a plea, if you have any information or knowledge about these groups or organisations that are working with groups, then pop them in the chat or let us know, because it would be really good to make those links. Next slide, please. So yeah, so as I said, we don't really have a lot of information on these groups. So this is some information that we pulled together a while ago, and we're trying to update, but kind of I think it just shows that we need to do more work to understand these groups. Okay, next slide, please. So just to touch on COVID, as I said earlier, health inequalities have really kind of been highlighted by the pandemic, and COVID has really kind of replicated, but also increased some of these inequalities because it's had a disproportionate impact on certain groups. And inequalities such as deprivation, low income and poor housing have always meant poorer health, and we've always known that there have been inequalities as a result of that, but it's been kind of really exposed, and the interconnections between ethnicity, gender and geography as well have really highlighted the vulnerabilities to inequalities. So it's really important. So when we're addressing inequalities, that we need to think about how we prevent poor health, how we improve people's opportunities, and that the structural inequalities in our societies, such as unemployment, overcrowded housing, lack of green space, are tackled as the root cause of inequalities in the long term. So it comes back to that. It's really important that we take a place-based approach working across the system. Okay, next slide, please. So just as a quick recap of kind of all the data, so this is what we're starting to understand about inequalities. There's an emerging picture and we're hoping to put this into a resource that we can share with people so they can kind of understand what are the risk factors locally and who do we need to target with our services and who are the groups that we need to engage with to address some of these inequalities. But there's a lot more work to do around understanding these inequalities and who's most affected by them. And then also the next stage of looking at equity of access and equity of outcomes to services and how we're responding as a system. Okay. I'm going to, so we've just finished that section. I'm going to look at how we can work together to address inequalities, but is there any, I'm just wondering if there was any questions or comments before I move on.
Chloe, there's a question. There's a couple of people have asked for copies of the slides afterwards. I'm assuming that we can organise that to go out to everybody that's registered today.
Yeah, absolutely. And this has been recorded as well, so I think people will be able to watch it. Happy to share the slides, and we're putting together a website where we can put, where we're going to host all of this information. So all of this work that we're doing and we're collecting information on, we're hoping to have some web pages where people can access all of this, because I think it's really important that we've all got a shared understanding of inequalities and how they're affecting people living in the county.
Okay, brilliant. And I see we've got a question from Chris Davison. He's got his hand up. So Chris, we'll just turn on your camera and mic. Or I will try and, your camera should be on now.
Chris, you'll have to turn your camera on.
There we go. Yeah, good. Hi, can you hear me okay?
Yes.
Chloe, thank you so much. I'm really enjoying this. I don't wish to interrupt your flow, but perhaps just to amplify, if I may, some of the points. This is a subject matter that I'm really passionate about. I'm lead governor for NHFT. I'm also public governor for NHFT, and I've been involved over quite a few years now in public-facing community engagement events and work that I do with other charities. And just to bring this into sharp focus, for colleagues on this call, only 20% of what makes a person healthy comes from healthcare. Just to amplify Chloe's point, and I'm going to say it again, it's so crucial, only 20% of what makes a person healthy comes from healthcare. We are a national illness service, a national repair service. 70% of all acute hospital activity is emergency driven. And as Chloe has illustrated earlier in a presentation, 40% is attributable to socio-economic factors. What do we mean by that? We mean education. We mean job status, family, social support, income, social status, community and psychological safety. 30% in terms of health behaviours, diet and exercise, alcohol use, tobacco smoking and healthy lifestyle. And 10% is where you live. And those factors here, I represent Corby here in the north of the county, and I see that. And one of the things that I've been doing over the last few years is hosting health and wellbeing days, whether that be in libraries, I've taken over shop fronts. And together with some of your colleagues, Chloe, back in 2019, took over a shop front in Kettering, together with colleagues from Age UK, Kettering Mind, KGH, Northampton Public Health Team. We screened 40 people. Your colleagues thought it was the best day ever. 3/4 of those people were screened had high blood pressure. That to me is about population health. And my final point, if I may, is that when I've done these events in the past, I've always seen it about three things. It's about prevention, early intervention and signposting. Post-pandemic, having set up a similar shop front with colleagues from the Kettering Borough Council, as it was, I also became very acutely aware that it was not just about those three things of prevention, early intervention, signposting, but it was also advocacy. Advocacy for people because of the colour of their skin, because of race, because of disability, have nowhere to go, no one to speak up for them. And we were dealing with issues not just about health, but also housing benefit. Because again, if people are living in poor conditions, they're not going to be healthy. And I would conclude, if I may, by saying, as you've highlighted, Chloe, that the fault lines in society around social economic factors, inequalities, have been cruelly exposed by the pandemic. And I applaud you for this. And I hope it will be shared widely, particularly with some of your senior management colleagues. But please also remember that as governors, we can get to places you can't. Part of our role is representing the public and members of the trust. And we can make things happen in a way that hopefully will fit your agenda. Thank you for letting me address the meeting. Thank you.
Thank you, Chris. And I think I've got another hand up. Sharon, we'll just turn your, enable your camera. You will need to just switch it on.
Thanks, Anne.
There you go, Sharon, you're all on.
Thank you. Sorry, I'm in a very snuggly jumper today because I'm cold, so very unprofessional. And Chloe, that was excellent. That was really interesting. I just wanted to ask, I'm a programme lead. I work across a regional footprint and developing services across different places and neighbourhoods. So I was just wondering, your last point there about the challenges, how do we share what we're learning so that we can address inequalities within our place and neighbourhoods locally, but also share learning when we're working across whole regions? Thanks, Anne.
I think that's a really good question, and I think probably regional networks are really key. So I know I sit on a regional network for inequality leads at the moment, and that's been really, really helpful for kind of sharing what we know. So I think there are different kind of levels, aren't there? Because I think there's kind of in a place that you're working, you'll have really good insight about that specific population and their needs and how we all need to work together to address that. But then there might be learning from that other regions would benefit from. And I think it's about that kind of networking. And NHS Futures platform has got some really good kind of inequality spaces on where people, I think it's just starting to get going, where people are sharing their learning, and there's some brilliant resources on there. So I think we need to use that more. But what we want to set up our own kind of web pages to sign people to as well, because I think NHS Futures platform is quite a NHS kind of thing that a lot of people who don't work in the system wouldn't know about. So we're trying to kind of develop our comms and marketing that we can all share and get together. And I guess the point that Chris, so thank you, Chris, as well for your comment. I think you've really highlighted and hit home the importance of this area and the importance of us kind of, we've all got our different roles to play, and one person can't address this on their own. We really need to work in partnership across the system in our different roles and be advocating for inequalities, using all the channels we've got available to us. So I think as everybody needs to think about, it's my job to think about inequalities and to advocate and to do as much as we can in my individual role, in my organisation, in my sphere of influence. So that's really important.
Thanks, Chloe.
Okay, thank you. So the next section was to kind of look at how we can address inequalities. So I just wanted to start with, next slide, please, looking at kind of how the NHS has really started to highlight inequalities. So in the long-term plan, they've really prioritised inequalities, which I think much more so than previous years. So it's being kind of put forefront and centre stage. And there are 5 inequality priorities in the long-term plan around how do we restore NHS services inclusively. So post-COVID, as we're getting kind of services back on track, everybody's been asked to look at how they bring those services back online, but thinking about those inequities and improving access for all the different groups. And the second one kind of follows on from that, mitigate against digital exclusion. So during COVID, a lot of services have gone online, working remotely, and that is, while that has worked for some people, and actually it has widened out access for people who maybe work shifts or work and they cannot get to kind of 9 to 5 appointments, it's also excluded a large group of the population who just don't have that digital access. So the NHS has been asked to look at how they can address that exclusion. Ensuring data sets are complete and timely, and that kind of links to my previous point about ethnicity not even being recorded. We need to make sure that we understand who's accessing our services so we can look at those inequities. So we need to start to record the different kind of demographic details of people so we can do that analysis and do equity audits and make sure we're reaching all the groups that we should be. Number 4 is about accelerating preventative programmes that proactively engage those at greatest risk of poor health outcomes. So that is, again, looking at who are the groups that are most vulnerable to inequalities and how can we work with those groups to improve access and outcomes to services. And the final one is around strengthening leadership across the system for inequalities. And I think all NHS organisations now have an executive lead for health inequalities, and that's really kind of raise the profile. And again, comes back to that point about how we all kind of have our roles to play and really need to start thinking about this for everything we do. And so alongside the 5 priorities, there's a new model of working that all systems are being asked to implement. And they're just, it hasn't been published as a final document, but I've been to a lot of webinars now where they've started to talk about this, and we're starting as a system to have to report back on what we're doing to use this approach. And it's called the Core 20+5. So the Core 20 is thinking about those who are living in the lowest 20% IMD areas, so the areas that I talked about in an earlier slide, plus ethnic minority groups, and then plus any other local population groups locally. So we know that people living in the top 20% most deprived areas and some ethnic minority groups are at risk of inequality. So we're being asked to think about how we're working with those groups. But then there's recognition that there are other groups, that local areas, and that will vary across the country. So different areas will have different population groups, and it comes back to that. Do we know who our groups are locally that are most at risk of inequalities, and how do we gather that understanding and information so we can target those groups more? And then they've given us 5 areas to focus on, that the NHS have said that this will do most to reduce inequalities. And these are clinical areas, so obviously we recognise that there are we need to also think about the wider determinants, but from an NHS perspective, it's these 5 clinical areas that are most likely to reduce inequalities. And they've been chosen based on premature mortality, and the other long-term commitments. So they are blood pressure detection, and links back to your comment about screening. And I think there's in the recent round of kind of planning documents, there's a lot of a push to how can we work in communities to do kind of programs where we do outreach and do more blood pressure screening, and pharmacists are now, I think, being asked to help with that. So it's how do we work in communities to identify those with high blood pressure and get interventions in place. Cancer diagnosis and screening. So we know there are big inequalities in that area. Chronic obstructive pulmonary disease, annual severe mental illness and then disability health checks. So again, we know that there's a big life expectancy gap for people for these groups compared to the general population. And maternity. So again, there are really big inequalities in the maternity outcomes, both for infants and for mothers. And one of the things that they've said will really have an impact is having a continuity of carer, but there's also a whole host of other things that we need to put in place to improve maternity outcomes. Okay, next slide, please. So in terms of how we think about inequalities and how we start to address those as a system, so what NHS England is saying we need to take a quality improvement approach. So we need to embed inequalities as part of our quality improvement processes, and that will enable us to transform services and to address inequalities. And services really need to think about what they are doing and how that is impacting on inequalities, and to make sure that we don't inadvertently increase inequalities. So through kind of increasing access to services, so we're going to increase the number of staff, we can put in loads more appointments, and it's kind of self-referral, so that will make it easier to access our service. Actually, that could inadvertently increase inequalities, because the people who self-refer are probably those that have really good understanding of their own health, of what services are available, what they're entitled to, and feel confident to ask for that help. So all of that group will access those services, and then there's all of the kind of vulnerable and disadvantaged groups might not access that service. That will widen those inequalities. So services really need to think about how they adapt services to meet the needs of different groups, and don't just take a universal offer. And so there are kind of different phases that we can go through when thinking about how we consider inequalities, and this is going to be part of the toolkit that we're putting out. So in terms of starting to think about what you're going to be delivering, you need to think about what is it that you're trying to achieve, and who are the service users, who are the potential service users, and who are the different groups, and how do we engage with those groups to make sure that what we're designing meets their needs and is accessible and gets good outcomes. And part of that will be looking at what the evidence is. So it's the local needs assessment. What do we know about the local population? What is the evidence telling us about the different groups, and what drives those inequalities, and what else is influencing their health? So pulling all that together, we could then inform what we're going to propose to do and how we plan, and kind of what we do to address those causes, how we make sure we're reducing inequalities and not increasing them, and also how we work with communities. So we need to think about who are the groups that we need to engage with, how are we going to work in partnership with them. And I think that's really important, that we're not kind of going out and doing to people, but we're working in partnership with people to develop and co-produce services that meet their needs. And then that we're constantly evaluating and looking at what the services that we've put in place, how are we doing on addressing inequalities, what are the outcomes, who's accessing those services, and constantly kind of reviewing and amending services to meet those needs. Okay, next slide, please. So Public Health England, a few years ago now, put out a kind of a toolkit for taking a place-based approach to reduce inequalities, and they've created what's called a population intervention triangle. So it's made up of kind of 3 elements and then kind of different aspects. So I'll talk through the 3 elements. So next slide, please. So the first is civic level intervention. So that's the local authority. So local authorities provide a whole range of services to the community and really address those kind of wider determinants of health. So there's economic development, employment, environment, planning, social care, community safety, policy and strategy development. There's a whole host of services that have really big impacts on those kind of wider determinants and inequalities. And so they're a key part of a place-based approach and really need to be working in partnership with people across the local authority. And one way of trying to get health, to get all partners thinking about health, particularly across the local authority. So how do we get planners to think about health inequalities? How do we get economic development to think about it? Is to take a health and all policies approach. So that's kind of putting health at the heart of all decisions and everything that we do. And we're kind of working across both councils to look at how we can make sure that health is embedded in all of our decisions and how we're designing programmes of work across the council. Next slide, please. So service-based interventions, which I think most aligns with kind of NHS, and this is a really busy slide, but I'm going to try and talk through the details and hopefully it will be clear. So services can achieve significant outcomes for individuals because they have a direct impact on individuals and their outcomes. But the services really need to be designed so that they reach the populations who are most at need to address inequalities. And while there is the potential for services to demonstrate a population level change through meeting the needs of lots of individuals, it often doesn't have that population level impact because there is variability in the quality of services and the way they're delivered. So that's looking at the effectiveness of services, the efficiency and the accessibility of services, or that there's variability in the way the population uses those services. So different groups have different knowledge, skills and health-seeking behaviours and resources, so that the uptake of those services is different. So if we really want to impact inequalities, we need to make sure we have good quality and delivery and access to services. But they're still not going to have an impact on inequalities at a population level unless you work with partners and give a kind of targeted support to those who are at the greatest need. So this model kind of has three different elements to it. And so I'll keep the picture up, but I'll talk through the different elements, and they are on the second slide as well, but it might be helpful. So in terms of direct service delivery, we need to use strong evidence-based interventions, so things that we know works, interventions that are effective, and for them to be effective, we need to have good governance, audit and evaluation of services, training staff, and continuous quality improvement, so that we are constantly reviewing how effective our services are and whether they're achieving the aims and addressing those inequalities. They need to be cost effective, efficient and have a return on investment. They need to be accessible, and that accessibility needs to favour the disadvantaged so that there is access, and then we need to think about access, what the offer is and how it meets different people's needs and choice as well. So different groups have different preferences in terms of how they want to access services, and that will affect uptake to services. And finally, it's about engagement, both with service users and with potential service users, and that they're involved in from the design stage to feedback on their experience of using services, and also involved in delivery of services. And then the population focus is looking at potential beneficiaries and communities. So that's making sure we are basing our service decisions and delivery on understanding of the needs. So who's most at risk, what are the local assets, what are the kind of multiple risk factors that we need to think about. Unmet need and demand, so who is it that isn't accessing the service, and who is it that isn't getting what they need, and who's getting the worst outcomes. Targeting resources towards equitable outcomes, again, trying to move the most disadvantaged the furthest and fastest, so really kind of thinking about how we allocate resources to meet those needs of the most disadvantaged. Improving service user engagement and utilisation, and looking at how we support self-managed care. And then to kind of balance those two elements, so the direct service delivery and working with beneficiaries, we need to look at service volumes to make sure that they can accommodate that previous unmet need. Because if we're going to work with groups and drive and improve access to service, we need to make sure that services can meet those needs. We need to make sure that the pathways are balanced and there's no potential for bottlenecks. So we're not going to generate loads of referrals and then people are going to kind of be stuck at assessment stage. We need to make that pathway open and smooth. And we need to make sure there's good leadership and coordination across pathways. Okay, next slide, please. I'll jump. I've just talked through that, so jump over the next one. And then the third part of the triangle is about community-based interventions. So it's really important that all partners, including communities themselves, understand the benefit and potential that working with communities can have to address inequalities. So that's thinking about community assets such as skills, knowledge, social networks, and community organisations as those building blocks for better health. And communities can be geographical, but they can also be groups that have similar interests or backgrounds. So we need to think about, when we use the word community, it's not just about geographical, it might be about kind of other types of groups as well. And Public Health England developed what they called a family of community-centred approaches. So again, they went away and looked at all the different ways that we can work with communities and presented a bit of a model so that people can look at what are the different ways we can work with communities and how do we achieve that. And it really highlights how we need to work with communities and build that kind of community capital to address social exclusion or lack of social support. And Michael Marmot has really highlighted that if we want to address inequalities, we really need to improve that community capital and reduce social isolation, because social relationships have such a core influence on inequalities. And that's also thinking about things like control and decision making and those kind of power balances. So how do we share the power and move away from those unequal power imbalances to come back to thinking about how do we give communities back power to think about decisions about them, about their community, about how resources are allocated. And so this kind of family of methods is a way that we can work with communities. So when we talk about community-centred, we're talking about non-clinical methods, participatory approaches, so actively working with the community, reducing barriers to engagement, building on community assets, collaborating with people most at risk of poor health and challenging the conditions that drive poor health, and prioritising and thinking about those kind of social networks, social capital and empowerment and control. So the four parts of the family of approaches are strengthening communities. So that's thinking about community development, asset-based approaches. So working with communities to look at what their local assets are. How do we empower communities to co-produce their own solutions and to work locally? And I guess that comes back to what one of the projects that we're trying to do at the moment is to recruit community development workers who can do this and work with our most vulnerable communities to look at how we can work with them to improve health and well-being, and also to work with services to improve access and outcomes. And there's volunteer and peer roles. So there's kind of lots of different ways that residents can kind of take on peer roles and volunteer roles, and they've been shown to have a really positive impact in terms of kind of control and empowerment, and also creating that pathway into employment, building up people's confidence and kind of giving people options for the future. And I think mental health and drug and alcohol services have kind of led the way a little bit, and really have got some really good case studies and stories about how they work with service users who become peers and are involved in delivering services. The third one is collaborations and partnerships. So that's kind of co-production, community-based participatory research. So how can we train up local communities to gather insights and share those insights and then make action plans based on what they know about their own local community? And it kind of comes back to empowerment and working in partnership with communities again. And then the fourth one is around access to community resources. So how do we make sure that services are accessible and in places where people want to go and can access them, and that people know about them. So one example is social prescribing. So we've got social prescribers working from primary care network, so all GPs now have access to a social prescriber, and then we've also got Public Health and the CCG have funded a kind of an additional social prescribing service for people who have multiple long-term conditions and other kind of risk factors, and they'll have access to a social prescriber for up to a year to work with them to help identify networks and services that they can get support from. Okay, next slide, please. Okay, and then so there was the 3 segments of the triangle, and then in the middle is place-based planning and leadership. So while the three elements of the triangle can separately generate changes at a population level and influence the inequalities gaps, we really need to pull together as a system and work together in a coordinated and multifaceted way to have the most impact. And that involves having good leadership and senior experts that represent the whole sector, from the local authority, health and related services, as well as the voluntary and community sector, so that we can better share understanding of needs and assets. We can have shared priorities and objectives. We can think about interventions and the whole pathways and outcomes. So rather than kind of working in silos and thinking about how we're going to do things individually, how do we come together to have cross-organisational programmes of work and oversight of that work? And I think the development of the integrated care system is a real opportunity for us to do this and start to work as a system to address inequalities. And also, just to add, all integrated care systems are being asked to prepare a plan on how they're going to address inequalities. So that plan has to be approved by March of next year. But again, we're just starting to look at that plan. So starting with that needs assessment again, so understanding who our local population are, and then we're going to have to go through a process quite rapidly because we've been given quite a short time scale to do it, but a process of putting in place a plan as to how we're going to work together as a system to address inequalities. Okay, next slide, please. And then within the triangle, there are seams. So there's kind of how do we work with communities and how do we join up those elements of the triangle? So there's how do we strengthen community action? So that's working with partnership with local communities to empower them and support them to become more resilient. There's civic service integration. So how do local authorities work more closely with the providers of services? And then finally, there's how do services engage with communities? And so I think all of us in our kind of respective areas need to think about how we join up and do engage more with communities. And then, sorry, I feel we're overrunning a little bit. So just to kind of wrap up, I'm going to talk about what we're doing locally to try and pull a lot of this work together. So on to the next slide, please. So I think, as Sally's mentioned in the chat, we're developing a toolkit that will support people across the system to understand inequalities. So through training, through provision of resources, through the provision of data, and to look at what we can do to take action on inequalities. So part of it is around how do we understand how our services or how our decisions or what we're planning will impact on inequalities. So it's using health and equality impact assessments more, or looking at what we're already doing and whether how they're influencing inequalities. That's how to use equity audits. And then there's the whole kind of the importance of engaging with communities and co-production. So I think we also need to make sure that everybody is skilled and confident to work in partnership with communities. So that's that co-production element. And we will be putting some web pages up with links and kind of, yeah, it'll be a really good resource that we can signpost people to. And then finally, we are, as a system, we're proposing some principles. So next slide, please. We're proposing some principles that we all kind of sign up to across the system. So all organisations will sign up to these principles for how we work together to address inequalities. And we're hoping we're just going through the transformation board at the integrated care system to get approval to put in place a system-wide charter. But these are the kinds of principles that we expect people to work towards, and that is recognising that inequalities is all of our business, and we've all got a role to play in this. That everybody has the training and skills and knowledge on health inequalities and inequities and what we can do together to reduce them, and that's what this training is kind of start of. That prevention is really essential for improving health equity, and particularly that targeting the most disadvantaged, and how do we look at the causes of inequalities and inequities and address those. The importance of the role of anchor institutions, so the big organisations working across the county, such as the council, the university, the NHS. How are we recognising our role as employers of people, as buyers of services, to make sure that we are influencing the local environment? How are we impacting on the environments that we're operating in? So I think we really need to think about our roles as big institutions and what we can do to address inequalities through that function. Better use of data and understanding of inequalities, so that's both through kind of what quantitative data, but also the qualitative and understanding, and improving the completeness and consistency of data, as I mentioned earlier. Taking a health and equity in all policies approach, working in partnership with communities, making sure that decisions around the deployment of resources will address inequalities, and also that we work together to understand and mitigate against some of those impacts of COVID that have really highlighted those inequalities. So I did want to get some feedback or thoughts on any of these. So if you could pop them in the chat, and understand that people do need to head off because we've run out of time. But yeah, it'd be good to get some feedback, and happy to take emails or conversations offline as well if people want to follow up. Chris.
Yeah, come on, Chris.
Yeah,
we should be able to switch your camera on.
For you. I've got an invitation for you. I think, Chloe, it's not a question. I will help set up a drop-in session at Tesco's in Kettering, because one of those 5 clinical streamed, I think, was about blood pressure. And I can set up you having a stall there at the front, because we've got to go to people. They're not going to come to us. You talk about working with communities. Let me work with you, and let's do that early in the new year. And I'll set one up in Corby as well. Thank you.
Okay, thank you.
Brilliant. Thank you, Chris. And apologies to colleagues on the call. We have overrun a little bit, but I'm sure you will all forgive us. It's such an important topic, and there is so many. I'm sure we could have gone on for a whole lot longer in terms of digging into the information. Whilst I'll ask colleagues on the call if they have any questions, but a question I'm going to ask Chloe is just in terms of Sharon talked about the difference that we can make in terms of the region and in the areas of our sphere of influence, but what difference can individuals make?
Hope Labour.
Keeping this agenda in mind.
I think it's that it is just viewing everything through an inequalities lens. So I think it's when you're making decisions, or when you're reviewing, if you're delivering services, is thinking about how, do you understand who it is that you're working with and the groups, and what you're designing, is that going to create inequalities, and how do you address those, and how do you reduce those inequalities? So it's about working with the groups that you need to support to reach services, and that kind of co-production. So understanding what it is that you need to put in place that's going to make your service more accessible. How do you develop communications that are going to reach the right audiences? How do you ensure that people are going to come to the service and get the best outcomes? How do you need to adapt your services? So I think it's just viewing everything through an inequalities lens, and thinking about how you work in partnership with those communities and get that feedback, because if we don't work with people, then we don't really understand what their needs are, and how to put the right things in place.
Brilliant. Okay, thank you very much, Chloe. I don't think we've got any more questions in the chat. I know colleagues have had to leave because they've gone to other meetings. Sharon has emailed me her, Sharon Smeaton referenced a toolkit that they use in I think it was Cam's, so we'll circulate that, and we will also circulate your slides as well, Chloe, so colleagues have got them to reference. But thank you very much. I know it was a really informative session. There's so much information in that, so thank you very much for taking the time to be here today. I'm just going to move through and just remind colleagues that we have got a feedback survey, so if I could ask you, and my colleague Louise will stick into the chat the link for feedback, so feedback on this session, but also ideas for future sessions. And we want to bring more of our local experts like Chloe into our system to share, so that we can connect and learn and share information and make the difference for the people in the county that we serve. So I'm just going to move us on. So our next session is on the 2nd of November, and I can't quite believe that we are talking about the 2nd of November. I don't know where the year's gone, and it's all about reaching out and saving a life. So it's about suicide prevention. So we've got some local experts and a regional expert that's coming to talk to us on that. So please, my colleague Louise will share the link to book up, and we're going to have many more of these sessions as we go through this year and into next year. But thank you all very much for joining us today. Thank you to Chloe for a really informative session, and enjoy the rest of your Tuesday. Have to think then, and stay safe. Thank you.
Thank you everyone for joining.